Okay, so my name's Chris Fagg. I'm a health advisor from Solihull. So I'll just be running you through this presentation on menopause and the effect it may have on female physiology. Okay, so this is what I'll be covering over the course of the presentation. I'll start off by outlining some key gender differences with a particular focus on the effect of the menstrual cycle. I'll move on to talk through some physiological changes that happen at menopause, the effect of menopause on bone health, the consequences of menopause for body composition, and then move on to some practical recommendations for diet and exercise for postmenopausal women. So women are not just little men, and this is often how they are presented with regards to their physiology. Under a microscope, their bone, muscle tissue, organ tissue may look almost identical to that of a man, just some very small differences. But it's at puberty that the obvious physical changes start to occur between sexes, and this is when the reproductive hormones are produced. So men will start to carry more muscle, whereas women will carry more total body fat, particularly on their lower body, whereas men will have a more centralized body fat patterning. So I'll just run through the impact of the menstrual cycle, because it's the absence of these hormones which is so important post-menopause, and I'll refer to the different phases during the presentation later on. So what you can see here is a normal menstrual cycle. Obviously there are huge differences between individuals and even within individuals month on month, especially with the use of hormonal modifiers, the main one being different methods of birth control. But for the purposes of this presentation, I'll just refer to this typical hormonal profile. So typically a 28-day cycle can be split into the follicular phase at the start for the first 14 days and the luteal phase for the remaining 14 days. And these can further be broken down into their early and late phases. During these phases, estrogen and progesterone do show complex overlap, and this impacts on one's physiology. So as you can see, progesterone remains very low during the follicular phase, with a gradual increase in estrogen before a surge leading up to the release of an egg from the follicle that is developed under those conditions. Ovulation marks the middle of the cycle, and it's accompanied by a brief spike in testosterone and an increase in basal body temperature of up to 0.5 degrees Celsius. So there is also an increase in metabolic rate that happens at this point and can carry on, or it's slightly raised for the remainder of the cycle. But this is offset by an element of leptin resistance. Leptin, being the hormone secreted from fat cells, sends the message to the hypothalamus to indicate satiety and inhibit hunger. And this resistance may cause an increase in calorie intake that far outweighs the increase in metabolic rate seen during that second half of the cycle. Physiologically, menopausal women will tend to have a similar profile to that seen in the late luteal phase of the menstrual cycle, where both the main reproductive hormones are low. Hunger may be increased, insulin sensitivity is reduced, leading to less stable blood sugar levels, and water retention can also be higher. So that table there just shows the main differences that can occur within a normal cycling woman, and they are very pronounced. Obviously the effect of the hormones on different individuals will vary greatly, but this is generally what's seen. So moving through to just talking through the changes that happen at menopause. So what you start off with is perimenopause, or which is directly translated to near menopause. And this is when the changes occur that as a woman begins to transition into menopause. There are four main situations. You've got early and late perimenopause. You've got menopause with the use of HRT and menopause without the use of hormone replacement therapy. For the most part of this presentation, I'll be focusing on menopause without the use of HRT, and we'll move on to that in a bit more detail shortly. So perimenopause will typically occur in a woman's 50s, although it's possible to begin in 40s or even 30s. The average age is around 51. It can last between 12 months and 4 years, some cases even longer. It consists of, as I said before, early and late phase, depending on the hormonal profile that's seen. And it's at this stage when menopausal symptoms begin to appear, so hot flushes, mood changes, night sweats, sleep issues, and the list goes on. Early perimenopause, estrogen is unstable, but on the average it's unchanged really from premenopause, while progesterone is low. And essentially what you see is a follicular phase type physiology. If you remember back to that graph where you've got increased insulin sensitivity, hunger level was stable, and you actually have a decrease in fat storage. Moving through to late perimenopause, so this is similar in its physiological effects to menopause itself. You have a decrease in estrogen along with progesterone, and you're almost in an androgen-like state. Androgens being the male reproductive hormones. You get an increase in muscle loss, an increase in fat storage, some insulin resistance, a decrease in basal metabolic rate, and this will be accompanied by a change in body fat patterning. And we'll go on to look at this in a bit more detail shortly. So menopause itself is defined as when a woman has not had a menstrual cycle for 12 months. The reproductive system has effectively shut off, and you have much more pronounced side effects, the night sweats, hot flushes, things like that. Again, these may differ significantly from person to person. Estrogen levels are as much as 95% lower than they were pre-menopause, and immediately after menopause, testosterone levels can be slightly elevated, again creating an androgen-like state where androgens, or the male reproductive hormones, are having a larger effect than they were previously. And this can cause an increase in the insulin resistance, as with late perimenopause, an increase in body weight, an increase in total body fat, and you'll see a shift to a more male-like central body fat pattern, and in turn this leads to an increase in heart disease and diabetes risk. The lack of estrogen also causes an acceleration in the rate of bone loss, which increases the risk of osteopenia and eventually osteoporosis. And again, we'll move on to bone health shortly. So HRT, as the name suggests, is essentially the synthetic replacement of the female reproductive hormones. Much of the controversy surrounding HRT goes back to the Women's Health Initiative study, which began in '93 and looked at various interventions on postmenopausal health. The hormone therapy trials using both combined and estrogen-only treatment were both stopped early due to more harm than benefit being seen, particularly with regards to an increase in risk of breast cancer and stroke. More recently, though, views may be changing on it, and if put on hormone replacement treatment soon enough after entering menopause, the potential benefits may be significant and potentially outweigh its drawbacks. Certainly our local consultant gynecologist is a proponent of the treatment, given the right circumstances, but this would obviously need to be discussed with an individual's primary practitioner. As I mentioned before, the rest of this presentation will focus on the effect of menopause on a woman's physiology without the use of hormone replacement treatment. Okay, so as I touched on before, bone health is compromised by the menopause, as a deficiency in estrogen leads to an increase in the loss of bone mineral density, and this can cause a subsequent increase in fracture risk. However, good levels of activity and proper nutritional support can actually help increase bone mineral density, or at least can stabilise it, even in postmenopausal women. A potential increase in bone mass maintenance is lower in postmenopausal women than it is premenopause. But a postmenopausal woman with 1.5% gain in bone mineral density over the year, as opposed to losing 1.5%, is still 3% ahead of where she may have been, and this can be a significant difference. In terms of nutritional support, adequate calorie intake is important, along with sufficient calcium and vitamin D. And I'll move on to nutritional recommendations in a bit more detail later. Exercise-wise, the list there shows kind of the order of importance or the order of benefit seen in the research. So jumping sports can have the biggest positive impact on bone density, but obviously it requires proper technique, whether that's dancing, gymnastics, things like that. Weightlifting comes next. Walking or running, where you have that repetitive impact, is next. And surprisingly, a lot of the research, it shows actually a more negative impact of sports without kind of repetitive impact, things like cycling, swimming, stuff like that. Although I'm sure if the resistance when cycling or swimming was great enough, there would be some positive impact. But I guess the reduction in gravity is having an impact there. 12 to 15 reps at lower weights has been found to have a sufficient positive increase in bone mineral density in postmenopausal women. The optimal, however, is found to be heavy loads, sets of 5, but this obviously must be worked up to gradually. And for optimal results, running and heavy weight training is the best, but even 20 vertical jumps a day have been found to stimulate an increase in bone mineral density for postmenopausal women, and that's an important consideration. So body composition. So in combination with sarcopenia, or age-related muscle wastage that happens in both men and women, you see an accelerated decrease in lean body mass that can occur due to loss of estrogen signaling, although sufficient protein along with resistance training can offset this. I believe the volume of recent evidence supporting the benefits of increased protein intake with age will eventually lead to a change in the recommendations, but as much as double the recommended or the current recommended daily intake, about 1.2 to 1.6 grams of protein per kilogram, may actually be necessary to maintain lean body mass, and these intakes are found to be fine in those without existing kidney issues. However, more recent research that I've read through suggests it may be the amount of the amino acid leucine which is most important rather than the total amount of protein itself. But that research is in its infancy at the moment. So due to the effect of androgens, or the increased effect of the androgenic hormones, postmenopausal women do begin to see a shift from a lower body fat patterning to a more centralised body fat patterning, with more visceral fat leading into an increase in insulin resistance, and that increase in heart disease and diabetes risk. So visceral fat is highly metabolically active, a lot more so than lower body subcutaneous fat. So it stores easily, but also releases easily. Its loss may not cause that much change in appearance, but it will have large implications for cardiometabolic health. The graph on this slide, just in the corner there, it shows the difference between men and women in terms of their fat storage. The black bars represent visceral fat levels. You can see they're much higher for men than for women. Post-menopause, women will start to show a pattern much more like that of a man, with a reduction in the subcutaneous fat storage and an increase in visceral fat. Chronic stress can cause an increase in cortisol levels, and over time this can increase fat storage, and also the leptin resistance that develops with a deficiency in estrogen may cause food intake to increase, leading to eventual fat gain. And in both sexes, you see an increase in the overall stress response with aging, and this is found to be up to 3 times higher in women than men. And again, decreased reproductive hormones are found to be most responsible, but it is possible for exercise to reduce this stress response. There is a hormonal impact with menopause causing weight and body fat gain, although primary factor is still balance between calorie intake and calorie expenditure. Indirectly, things like the increase in leptin resistance that I just talked about can tip the scale somewhat. And there is actually some limited research that has shown weight gain independent of energy balance in postmenopausal women. But we'll just talk through the different components to the energy balance equation. So in terms of energy intake, very much like pre-menopause, is simply the amount of calories provided by the food and drink consumed each day. And the laws don't really change when you've moved into the menopause. So proteins and carbohydrates provide 4 calories per gram. Dietary fat provides 9 calories per gram. Alcohol, 7 calories per gram. Just embolden that because in postmenopausal women you may see an increase in alcohol consumption. Due to its toxicity, alcohol will be the first macronutrient or the first energy to be used, and if consumed with high fat food, then fat storage can be significant. So yeah, the laws in terms of the macronutrients don't really change. What may change is the ideal macronutrient composition of the diet, and this is mainly down to the increased insulin resistance after menopause. So along with a higher intake in protein to help maintain lean body mass and increase satiety and a feeling of fullness, postmenopausal women may want to consume more fats and less carbohydrates than they were pre-menopause. The potential for increased water retention post-menopause can often be offset somewhat by the decreased carbohydrate intake. As to store carbohydrate in the body, it can require the storage of 2 to 4 grams of water per gram of carbohydrates. This is a consideration to make when looking at the number on the scales. The table shows potential recommendations for somebody consuming 2,000 calories per day. Obviously, that absolute calorie total will vary depending on activity levels, starting weight or lean body mass, and the target weight or body fat loss that they're trying to achieve. But certainly a higher protein intake and potential for a lower carbohydrate consumption may be advised, which will be slightly different to what's represented in the Eat Well guide. And this is just things to consider when it comes to nutrition and the energy going in. On the other side of the scales, you've obviously got the energy expenditure. So the total daily energy expenditure, there's 4 main components to it. So the resting metabolic rate of an individual will actually provide or make up 60 to 75%. So often down to the amount of lean body mass, so the amount of skeletal muscle, but also organ mass. Then you've got thermic effective feeding, which is about 10% of an individual's energy expenditure. Slightly higher if protein intake is higher, but that's only marginal. The two that vary the most, you've got the thermic effective activity, which is basically formal exercise, running, weightlifting, whatever it might be, which is obviously hugely variable. 0 calories in someone that doesn't do any at all, up to thousands in someone that's marathon training or something like that. The other component, probably the most interesting one, is the non-exercise activity thermogenesis, which is basically your day-to-day activity, fidgeting, walking about, washing the dishes, things like that, which again is hugely variable. So 100 to 600 calories in someone that's pretty sedentary, doesn't really move about too much, and that can be increased to over 2,500 calories. Finding ways to increase that non-exercise activity thermogenesis is, as I said there, it's not only critical to increasing daily energy expenditure, but it has the potential to actually have a larger impact than formal exercise itself. And I'll often tell people that if at the gym for 4 hours a week, it's a very small percentage of the waking hours. So what you're doing outside of that is very important in terms of weight maintenance. And actually, so there's some interesting studies in women that have found that when thermic effective activity or formal activity is increased, then it can be compensated by a decrease in non-exercise activity thermogenesis. And this is obviously important to realise for women of any age, but particularly post-menopause, where in combination with the ageing process, you do see a decrease in the resting metabolic rate. This is due to a reduction in lean body mass and an apparent decrease in organ energy expenditure that occurs, which heightens the importance of maintaining the other contributors to total daily energy expenditure. So the non-exercise activity thermogenesis, or the NEAT, it really brings to play the importance of wearables and apps such as Bupa Boost that can play a big role in maintaining weight just by giving triggers to keep on the move as much as possible. Because despite there being no strong evidence to support the 10,000 step rule, hitting that target does show that there's a good level of daily activity or NEAT. Also, with age, there may be a greater adherence in hitting the lower level activity targets than with a more vigorous exercise program. And as with diet and exercise, adherence is often the most important thing. So moving on to some formal exercise recommendations for women post-menopause. So I've just outlined some practical recommendations there for an exercise routine for postmenopausal women just starting out and exercising potentially 3 times a week. So it would include 3 bouts of aerobic exercise at a low intensity. Ideally, this would be running due to its effect on bone mineral density. But as I just said, as with most nutrition and exercise plans, adherence is key. So it would be the preference of the individual on that one. It would also include full body resistance-based exercise, which is of more importance as we age, at rate of perceived exertion of 7 or below to begin with, to support the increases in bone mass and the maintenance of muscle tissue. For further support, they may want to include some jumping exercise, as we spoke through before, with that 20 jumps a day, vertical jumps, kind of providing significant effect on bone mass. So moving through to formal exercise recommendations for a more experienced individual or following fitness development of a beginner. The main changes to it would mainly be the frequency and intensity of the sessions. As you can see, the RPEs there have increased, and this is moving on to 4 exercise sessions a week. And on top of the weight training, the aerobic exercise, and possibly some jumping exercises, there is the potential for some high intensity intervals to be included and to provide extra cardiometabolic benefits and further contribute to weight loss if necessary. As with all forms of exercise, this should be safely built up too. Okay, so in terms of dietary requirements, the main changes there with menopause, that with the cessation of menstruation, iron requirements drop down to 8 milligrams per day. Calcium requirements will increase due to the decrease in bone mineral density. And another one that I've noted there is soy or phytoestrogens. So soy actually contains phytoestrogens, although these can be taken as a supplement. And phytoestrogens bind to the same receptor as hormonal estrogen. So the sensitivity to these receptors is actually stronger in phytoestrogens than it is with the hormonal version of estrogen. But the signal it sends is weaker. So what this may mean is that for normally cycling women, they may only want to consume small amounts because it can inhibit the normal estrogen signaling. But it could have profound effect for menopausal women not taking HRT and reduce some of the negative effects caused by estrogen deficiency. Soy-containing foods include tofu, tempeh, soy milk, and the many vegetarian meat replacement products that you see will often be soy-based. Okay, so potential for supplementation post-menopause. So in terms of getting the right amount of calcium in, it may be worth increasing or supplementing with calcium carbonate or calcium nitrate. There's an improved impact when supplementing morning and night, although should be careful with not consuming too much calcium, as there is links between that and cardiac issues. So yeah, certainly getting it through yogurt, other dairy products would be most advisory. But vitamin D, as with all other food types, we'd rather nutrients came from natural sources. But with vitamin D, this would mainly be from sunlight, which certainly in this part of the world we don't get all year round. Particularly winter, we don't get a good amount. But good dietary sources are also oily fish, fortified cereals and eggs. And particularly with elderly and menopausal women, the calorie consumption may be reduced and they may be exposed to less sunlight due to reduced mobility. And these factors may therefore increase the need for supplementation. As well, dark-skinned individuals absorb less vitamin D, so again, more potential for them to need to supplement. When it comes to supplementing vitamin D3 is much better absorbed with better efficiency than is D2. And intakes of 2,000 to 4,000 international units is found to be safe and should help bring blood concentrations above 50 nanograms per milliliter. And it is a fat-soluble vitamin, so I'd recommend taking it with a fat-containing meal. Again, due to the a tendency to consume fewer calories with age, in order to meet protein requirements, protein supplementation may be required, and in combination with resistance-based exercise, whey protein is found to have the greatest muscle protein synthetic response, with pea protein being the best of vegan sources for that. And again, touching on soy, so soy protein supplements or soy protein powder may have the benefit of increasing the estrogen signaling as touched on before, as well as providing an increase in protein intake. The table there just shows some of the most common supplements available on the high street to help reduce some of the symptoms that women may experience with menopause. The majority there have just anecdotal evidence at best, but most of them also have no side effects. The only exceptions to that are melatonin, which may cause drowsiness in some people, and also the DHEA, which is an androgen. It may interact with estrogen, reduce many menopausal symptoms, yet it can cause growth of facial hair and should be discussed with a primary healthcare provider before starting to take that. Aside from those two, if individuals do experience improved symptoms with the consumption of those supplements, they may take at the stated doses without any real problems. Okay, and thanks for listening.